We have a wonderful speaker today, Dr. Marc Carrier. We will explore the complex and evolving topic of thrombophilia workup. Advances in genetic testing and risk stratification have improved our ability to assess thrombophiliac disorders, but deciding when and how to test remain controversial and nuanced. Over and under the testing of thrombophilia can lead to a misdiagnosis or overdiagnosis. It's my pleasure again to introduce Dr. Marc Carrier, a leading expert in the thrombophilia. His research, particularly in the cancer-associated thrombosis, has shaped the clinical guidelines and improved patient care. So we are honored again, Marc, to have you here today to talk about thrombophilia testing.
Thank you very much, Dr. Bat, and again for the opportunity and the kind introduction. As you mentioned in the objective, this is a very controversial topic for which there's very little data. So it leaves clinicians like you and I sometimes in a knowledge gap or with uncertainty on what to do and when to do it. And the presentation will be illustrated by two different cases. And the point is not that there's a right way to do things or not, but probably just to make sure that you have a rationale. Thrombophilia testing should probably be not done on a routine basis. It can be done for certain patients. You just need to have a rationale for it. Make sure that you understand how it could change management for patients. And if it doesn't, and the patient is not necessarily interested in knowing, then maybe there's argument for not doing it, as it can lead to unnoticed problems down the road. As you know, in North America, if you're diagnosed with thrombophilia, it becomes a predisposing illness for insurance from a disability life insurance perspective. It can lead to over-diagnosis or over-treatment in certain instances, especially if patients are not seen in a specialized center. So there's pros and cons to thrombophilia testing, and we'll try to go through the different cases and see if we agree with the guidelines, because sometimes we need to apply the guidelines into clinical practice, and then B, make sure that we feel comfortable with this, and then that we change patient outcome for the better. So the first case is patient MC. She's a 28-year-old female. She's working at Starbucks. She has no private insurance. She has a normal BMI of 28. She recently started combined oral contraceptive 4 weeks prior to presenting to your emergency room with left lower extremity swelling. She's diagnosed with proximal deep vein thrombosis. In Canada and maybe part of the US, sometimes DOACs may be relatively expensive, so she's managed with a vitamin K antagonist. She has a good time in therapeutic range, and she has now completed 3 months of anticoagulation, seeing you in the clinic. She has no residual symptoms in her left lower extremity, no post-thrombotic syndrome. You do a baseline ultrasound to assess residual vein obstruction. It's within normal limit. You decide to do a D-dimer. It's within normal limit. She has discontinued the combined oral contraceptive while she was on oral anticoagulation. And then the next question is, what do you do with anticoagulation? Do you feel comfortable that this was a major transient risk factor and we discontinue? You may think this is maybe a minor transient risk factor you'd like to continue for an indefinite duration. Would you do thrombophilia testing and then discontinue anticoagulation? Or would you do inherited, acquired, or both? And then based on that, if positive, then you would recommend long-term anticoagulation for that particular patient. And maybe you'll have different opinion, but based on the current clinical practice guidelines from the American Society of Hematology, they would recommend thrombophilia testing for this woman. And if positive, they would suggest indefinite anticoagulation treatment if they have some form of thrombophilia. No difference between if it's acquired or inherited, and we'll come back to that. I'd like to highlight at the last sentence, this is a conditional recommendation based on very low certainty of evidence. So although they suggest, which means in the ASH language that probably a large number of patients should go through that particular step, there's some flexibility in how you interpret the data, and maybe some patients may not need to have thrombophilia testing and an indefinite duration for this particular event. you know, you're not an expert in the field. Let's say that you're a general internist, general hematologist practicing outside of an academic setting. You follow the ASH guidelines recommendation. She undergoes thrombophilia testing. She's diagnosed with heterogeneity for prothrombin gene defect. So based on the ASH guidelines, you recommend indefinite duration of warfarin. This is the interpretation that you do. Now the question is this the right decision for that particular patient? And that's why I'm saying sometimes you can do thrombophilia testing or not, and then making a decision about duration and anticoagulation is also an additional step that it may be hard for clinical practice guidelines to comment on. So what the American Society of Hematology have tried to do is to answer two questions with all the different cases that they mention, or the questions. So the first one is, should you do thrombophilia testing or not? The red box. And then afterwards, based on the thrombophilia testing result, should you continue anticoagulation long-term for singular prevention of recurrent venous thromboembolic disease? So, you know, it's hard to do these two things in one question. So in order to do that, they had to do modeling, looking at different numbers, trying to pick up what's available in the literature and apply it into a system, looking to see if we can make decisions based on that. But you can just see that when you're facing with your individual patient, there's a lot of limitation to modeling. And that's why there's a very low certainty of evidence leading to the very conditional recommendation. So for example, patients with different provoking risk factors may have very different risk of recurrence. Our patient NC just started the oral contraceptive pill, but maybe her risk of recurrence would have been very different if she had started it 5 or 10 years ago. Maybe her risk of recurrence would be different if this was not estrogen related, but maybe related to immobility because of a cast, or maybe related to prolonged flying, for example. So you need to be mindful that different provoking risk factors may have very different risk of recurrence. There's different types of thrombophilia. There's inherited, acquired. Right now, ASH is putting them together. And these different thrombophilias have different prevalence in the general population. And then they also have different risk of recurrent VTE. And we all know that the data supporting their effect on the risk of VTE, recurrent VTE, is, you know, controversial at best. And then finally, the last part, we're recommending long-term anticoagulation. They're putting all the different anticoagulants together, but I think you and I would agree that the risk-benefit ratio of continuing long-term warfarin is probably different than continuing low-dose DOAC, right? So all of these things needs to be incorporated in your decision. Now, we don't have a whole lot of time to go through all the different components that clinicians need to think about, but I wanted to focus that really we should look at what are the assumptions that they made for the risk of recurrence, because this is the starting point. You have a patient in front of you, you're saying, what's her underlying risk of having a recurrence if I stop anticoagulation? And then based on that, I can multiply it by the relative risk associated with the different thrombophilias. So if you look at the fine prints of the guidelines, they say that overall risk of recurrent VTE after combined contraceptive or postpartum is 50 per 1,000 in the first year following discontinuation of anticoagulation, so about 5%. And then based on this risk, on the right-hand side, you multiply it by the relative risk of VTE recurrence, so that would be the third column, associated with the different thrombophilias. Now, they decided to pull all the thrombophilias together and to multiply that rate by 1.65 for any thrombophilias. And if that rate is over the threshold for which you would recommend long-term anticoagulation, then it would say, yes, your patient needs to continue long-term anticoagulation. If it's below that threshold, then they would say, we can stop it. Now, your question is probably, well, where is that assumption coming from, that 5% following COC contraception or postpartum. It's coming from a systematic review that combined many of the risk factors with mild-provoking risk factors. So it's not only about postpartum or COC, there's also immobility, fracture, traveling, flights, all of these things. When they did a pooled estimate rate, it was about 5%. Now, in clinic, when you see a patient after 3 to 6 months of anticoagulation, and then you're thinking, should we continue long-term anticoagulation for standard prevention? You're thinking, well, it depends on your risk of recurrence. And that particular risk of recurrence will depend on if there's provoking risk factors, if it's unprovoked, or if it's provoked by persistent risk factors. Obviously, if you have cancer, the risk of recurrence is really high. It's a persistent risk factor. You'll continue long-term anticoagulation because if you stop, the risk factor is still there. They're likely to have a recurrence. If on the other side, if you have VTE post-trauma, your risk is really low, less than 1% after 12 months following discontinuation of anticoagulation. So you're not going to continue long-term anticoagulation because there's more risk of bleeding. What is a bit unclear is when you don't have any provoking risk factor or you have mildly provoking risk factors. So Clive Kieran and others have decided through the ISTH to have thresholds on what that risk is. And they made a decision that if your risk of having VTE within 12 months following discontinuation of anticoagulation is 5% or more, then you should continue long-term. And back then, you can see from the references, this is from 2016, it was warfarin. So you could argue that maybe it should be a bit lower. But overall, people agree if your risk of recurrence at 12 months following discontinuation is more than 5%, you need to remain on long-term anticoagulation. And for 5 years, it's 15%. Okay, so remember, 5 and 15 years. So does the 5% ring a bell to you? I just told you that their assumption for a risk of recurrence for that particular case was already 5%. So really what the ASH guidelines is telling you, it doesn't matter if that patient would have had thrombophilia and you multiply it by whatever relative risk you want, she is already at threshold to recommend long-term anticoagulation. So the real question for you and I is, do you really believe that her risk of recurrence, if she stops anticoagulation, is more than 5% after 12 months? And the answer to that is no. There are a number of systematic review. This is a relatively recent one done by Jamil Abdulrahman, published in the British Journal of Hematology, that they're saying the risk is not 5%, it's actually 1.2% per year. So it's a third of the assumption that they used. And remember, if you multiply this by 1.65, which was any thrombophilias, or if you multiply it by any of the relative risk that they had, the most was 2.1, you still don't get over a threshold. So maybe for that particular patient, if you're using other numbers, and then again, we're just looking at the number to start with, the risk of recurrence, then risk, maybe it's not worthwhile to do any thrombophilia testing in that particular patient and just stop anticoagulation because this may have been related to the COC to begin with. If you look at clinical practice guidelines, we said that, it's very low risk, very low evidence or low certainty of the evidence. Can't go any lower. So then the reflection is, well, why did they say a conditional recommendation suggesting to do it, and if positive, to do long-term anticoagulation? Well, there's the panel members will have a look at. They look at the balance of the effect, so the risk-benefit ratio. Although it didn't seem to be favoring, they seem to have think that that might be the case. They also look at cost-effectiveness analysis. Keep in mind that here, it's different than the other GASH guidelines because they're trying to answer two questions. So, maybe it's cost-effective to do some form of thrombophilia sometimes, but not for everyone. And then that is not associated with the decision of long-term anticoagulation. Similar for equity. They say, sure, thrombophilia testing is fine, but they don't comment on the fact that then you're committing that patient to years and years of warfarin or anticoagulation therapy. And then acceptability, of course. I think you and I would agree that maybe doing thrombophilia testing is acceptable for more patients, but I'm not sure that being on lifelong warfarin is, and that might have shifted the balance too. So I think because they tried to do too many things with one question, that led to some suggesting or recommendation that may be a bit of counterintuitive because of the model and the assumptions that they did and trying to do two questions at the same time. So this particular patient, I would argue that because her risk of recurrence, if we stop anticoagulation, is so low, even if you multiply it by any of the relative risk of any thrombophilias, it still would not meet the threshold for long-term anticoagulation, and therefore maybe just discontinuation of anticoagulation without testing may be reasonable. But as I mentioned, it all depends on the discussion that you have with the patient. Maybe she wants to know why she had a clot. There's other factors. But from a number perspective, this might be a reasonable option for that particular case. Now, you may be wondering, well, what's the benefit of long-term anticoagulation? Like, you and I are putting patients on long-term anticoagulation all the time. What's the benefit overall? Well, if you look at a different patient population, so patients with unprovoked venous thrombosis, so much higher risk of recurrence than patient MC, which was related to estrogen or COC, there's a modeling or cost effectiveness analysis that was done that was presented and published in Annals, looking at patients with unprovoked VTE. And even in these patients that have a much higher risk of recurrence, when you do indefinite anticoagulation, sure, you're decreasing the risk of VTE, but obviously you're increasing the risk of bleeding. The case fatality risk of bleeding is much higher than the case fatality rate of VTE. You're not saving money, you're costing the system money, you're not decreasing mortality, and you're not increasing quality of life for these patients. Now, obviously, this is modeling again, there's pros and cons, but when you see these modeling saying in a very much higher risk patient population, and then you're having a reflection, well, is this applicable to my patient with a much lower risk? Then maybe the risk-benefit ratio is not favoring long-term anticoagulation for that patient. But it's just something to consider when you make your treatment decision. Okay, so I wanted to go through a case where the patient may have had a provoking risk factor. And now let's have a discussion with a patient that does not have any risk factors. So patient MT, 35-year-old female, 2-day history of progressive left lower extremity swelling, no provoking risk factor, no relevant VT family history. She is not on combined oral contraceptive. Her BMI is normal. She does have proximal deep vein thrombosis. Laboratory investigations are done. They're within normal limits. So she starts anticoagulation. She has completed 6 months of anticoagulation. Similar to the first patient, her previous symptoms have resolved. No post-thrombotic syndrome. You do a baseline ultrasound for what it's worth. It's within normal limit, no residual vein obstruction. D-dimer is within normal. We have the same management options. What would you do for this particular patient? Similar, but at this time is completely unprovoked. Do you discontinue anticoagulation? Do you continue anticoagulation for indefinite duration? Do you do some thrombophilia testing to let the patient know what happened, but say your risk is still very low, so we'll discontinue anticoagulant for that particular patient? Or do you do some form of thrombophilia testing, inherited or acquired or both, and based on that, you make a decision about long-term anticoagulation, similar to what was suggested by the American Society of Hematology guidelines for our first case. So if you read the same guidelines, first recommendation for this particular patient would be do not do thrombophilia testing, just continue long-term anticoagulation, and that's based on the ASH VTE treatment guidelines, and that was recommendation 19, which to me as a clinician is a bit counterintuitive, because usually for provoking risk factors, I didn't really think about doing thrombophilia testing so much. I would think more about to do it when it's unprovoked, but the ASH is trying to change the paradigm a little bit, saying, for all these patients with unprovoked VTE, they should remain on long-term anticoagulation therapy, and therefore thrombophilia testing is not going to make a difference in that decision or not, therefore you shouldn't do it. So again, you're a conscientious clinician, Based on the ASH guidelines, you recommend anticoagulation, you don't do thrombophilia testing. Is this the right decision for the patient? And do you feel comfortable making that decision, committing this young woman to long-term anticoagulation? Well, I think there's other ways that you can stratify patients if they have an unprovoked VTE according to their underlying risk of having a recurrent event. And similarly, as we've seen before, it's important to know what that risk is, because if it doesn't go to the threshold, why would you expose your patient to anticoagulation, potential risk of bleeding? Maybe you should just say, well, we'll stop anticoagulation at that particular time. So there's different stratification scores that exist, helping clinicians to stratify patients according to their underlying risk of recurrent VTE. So one was Marc Carrier and colleagues published in the BMJ. Men continue, so men at high risk. If you stop anticoagulation for men, the risk within 12 months is probably around 14%. And then HER2, so women with post-thrombotic syndrome symptoms like hyperpigmentation, erythema, edema, redness, age, body mass index. If they have an Avidas D dimer, if they have 2 of these, they have a similar risk as men. But if they have 0 or 1, then they have a low risk of VTE. And remember, we talked about the threshold of being 5%. Low risk women would have about 3% upper bound of the confidence interval lower than 5%. So maybe these women could stop anticoagulation. Vienna rule has also been recently validated in the European Heart Journal. They use sex, location, and extent, so distal, proximal, PE, and a D dimer result. And then they provide you with a cumulative risk of recurrent VTE. And for that case we just looked at, it was 2.8% risk of having recurrence if you discontinue anticoagulation within the next 12 months. Upper bound, again, less than 5%. So maybe for that particular woman, the right decision would be to just stop anticoagulation, because the risk of recurrence is low, risk of bleeding may be higher long-term, higher case fatality rate compared to recurrent VTE. So I think in this particular scenario, it would be reasonable to contemplate stopping, but maybe then doing thrombophilia testing may be helpful to see if it would go over the threshold. So remember, the overall risk of recurrence, we've just put 3% here, 30 per 1,000. And if you just look at the numbers, if you looked at any thrombophilia, so that's again on your right-hand side, thrombophilia guidelines from the American Society of Hematology, if you do the multiplication, it's less than 5%. You could argue that maybe the upper bound would be more than 5%. But maybe if you look at their assumptions, that particular patients may not require long-term anticoagulation. However, if you look at individual types of thrombophilias, not necessarily heterogeneity for factor V Leiden prothrombin gene defect, but if you looked at antithrombin, protein C and S, if you looked at APS, their relative risk is close to 2. So then you could argue that maybe that's over your threshold of 5%. And maybe you should do these tests, especially if there's strong family history in that particular setting, because if they are positive, maybe you would have a discussion about continuing anticoagulation. May or may not be. Okay. For the particular exercise here, because the woman really didn't have a strong family history of VTE, it's really rare to get a new protein C and S and antithrombin. You could argue that if you don't screen, then you don't find homogeneous factor V Leiden or compound heterogeneity, but these are extremely, extremely rare. Just for the sake of discussion, decided not to do thrombophilia testing here and just discontinue anticoagulation, do thromboprophylaxis when the patient is in a high-risk situation, and have a discussion with her about the pros and cons of this. So if you want to have an approach to thrombophilia testing, was one of the things we wanted to cover today. This is a very nice review. It's relatively old now, only published in 2017, but Gene Connors from Boston has a very elegant narrative review on thrombophilia testing, which is aligning very much with what I do in clinical practice. So if you have a first unprovoked VTE, you have a discussion about the role of testing. You consider APS testing, obviously, if there's arterial and venous events, because that would be more typical for APLA or APS. And if the patient is young and has a strong family history, or if it's a female patient or they have female family members, then having a discussion on how to tailor anticoagulation, like we did, may be important. So we decided for Miss MT not to do any thrombophilia testing, but is there a role for thrombophilia testing if the anticoagulation is discontinued, like we did for our patient, and she's contemplating pregnancies in the future? She said, Doc, I know I'm done with this clot, but in a couple of years, I may want to get pregnant. Do I need to have thrombophilia testing to help me tailor anticoagulation? It's a great question, right? So how do we make a decision about providing antepartum or postpartum thromboprophylaxis in women that are pregnant? Well, we use thresholds. So what are the thresholds to decide on anti or postpartum thromboprophylaxis? We use thresholds of 3%. So if your antepartum risk of VTE in the antepartum period is more than 3%, that individual should receive some form of thromboprophylaxis. And if in the postpartum, and postpartum is only 6 weeks, it's more than 3%, then they should remain on long-term anticoagulation. How do we determine that? Based on the data we have. So this is ASH education that was done in 2017, summarizing these underlying risks. I like this particular table because it illustrates the thresholds very well. But if you look at unprovoked, so that would be the first line, you can see that women or females with a prior unprovoked VTE, if they're off anticoagulation and become pregnant, their antepartum risk of recurrence is 3.6% and 3.1% for postpartum, and therefore they would need thromboprophylaxis. If it's estrogen related, like it is for a first patient, that risk is even higher, antepartum and postpartum, and they need to have some form of thromboprophylaxis. If the risk or if the previous event is provoking trauma, immobility, then the antepartum risk is low, but the postpartum risk is high. And therefore, for patients with previous previous VTE provoked by major transient risk factor, we would only recommend postpartum thromboprophylaxis based on these estimates. Really, if you look at the pregnancy or prevention of VTE in pregnancy guidelines, recommendation 16 would say for a woman not already receiving long-term anticoagulation with a history of VTE that was unprovoked, then there's a recommendation for antepartum and postpartum thromboprophylaxis. Strong recommendation, low certainty of the evidence, and we just had a look at it. The confidence interval are relatively high. So for Miss MT, you could argue that doing thrombophilia testing is not changing anything because she needs to be on antepartum and postpartum thromboprophylaxis anyway. Now, the next question that she may have is there a role for thrombophilia testing if my sister is contemplating pregnancy? She never had a VTE, but she has a first-degree relative with VTE, and you can translate that to her daughters or whatever down the road. Is there a role for thrombophilia testing in that particular setting? And the answer may be yes, because depending on the thresholds, again, different types of thrombophilias may be associated with different risk of anti and postpartum in the setting of having family history. Now, keep in mind that, for that particular patient, Miss MT, and then she says, should I do thrombophilia testing to help my sister? My sister would be willing to be tested, and if positive, then she may consider thromboprophylaxis. Keep in mind that if Miss MT is completely negative for thrombophilia testing, the relative risk when you have a first-degree relative that has VTE is still 1.6, right? So that her sister is at high risk of having it. Not enough to go through the threshold, but probably to have some counseling and clinical surveillance, making sure she's aware of the signs and symptoms of VTE. So the reason why I'm saying this is don't be overly confident or overly reassured with negative thrombophilias in that particular setting. Family history remains an important risk factor. But if we go back to the fact that she wants to be tested, then the decisions to use thromboprophylaxis in pregnancy will be dependent on antepartum and postpartum thresholds. And this is in the same review. There's a couple of tables. I've put table 2 here, giving you a sense of what the absolute risks are. And if you look at what the recommendations are based on the threshold we just talked about, if you have factor V Leiden, heterogeneity for factor V Leiden, prothrombin gene defect, or if you have protein C and S, independent of family history, there's a suggestion against thromboprophylaxis in the antepartum period. If you have antithrombin deficiency, or if you are homozygous for factor V Leiden or compounded compounded heterogeneity for thrombin gene defect or factor V Leiden, then there's a suggestion to consider antepartum thromboprophylaxis. For postpartum factor V Leiden, prothrombin gene defect, you should not use postpartum thromboprophylaxis, independent if the patient has a family history or not. For protein S and C, there's a suggestion to do so. And similarly for antithrombin, or if you have homogeneity for factor V Leiden. So when you have a discussion with this MT, you say, well, if you don't have a strong family history, we could do these to make sure that there's nothing de novo that comes in. But although the yield of finding something is probably relatively low, we need to balance that with the pros and cons as we discuss about insurance and other potential consequences. But, testing for prothrombin gene defect, factor V Leiden, when it's not going to make a difference for her or her sister or daughters is debatable. You could argue again, then if you never test, then you'll never find the homogeneous factor V Leiden, but extremely rare. You could say, well, maybe antithrombin, if there's a strong family history, may be desirable, because then if your sister is positive, then NT and postpartum may be desirable. And in protein S and C, it's a suggestion, not antepartum, maybe postpartum, depending on risk-benefit ratio and discussion with the patient. But just to have a reflection about what are the consequences, are they, is the patient understanding what it means, and if they're tested, to make sure that the sibling would be willing to be tested, and if positive, willing to go on the intervention. Because again, these are numbers and suggestions based on very low certainty of the evidence. Antepartum, postpartum thromboprophylaxis is medicalizing pregnancy. It's associated with costs, can have some side effects associated with it. So there's things that deserves a little bit of attention. Now, if the patient, the next question is, what if the patients were compliant with clinical practice guidelines, and instead of having all that discussion, we decided to continue anticoagulation, and then the patient still wants to know why this happened and would be interested in having thrombophilia testing done. Can you do thrombophilia testing on oral anticoagulation? The answer is yes and no, and depends on the treatment. And I would recommend that you have a discussion with your lab to see what type of test or coagulation assay is used in your institution. And based on that, you may or may not be able to do certain thrombophilia testing, depending if your patient is on direct 10A inhibitor, direct thrombin inhibitor, or vitamin K antagonist. So this is a nice table that I like, that was published in 2017 in response to the narrative review from Gene Connors. But it shows you that some of these can still be done. Like if you have a chromogenic assay, if you're looking at free protein S immunoassay, if you're doing anti-cardiolipin, anti-beta-2 glycoprotein 1, but be mindful that depending on the assay, you may not be able to do all these. And it's important for you as specialists to know what you're actually doing, because you don't want to have, for example, a false estimation because you're using a 10A-based antithrombin activity and saying the patient does not have antithrombin, which could have consequences for the family if you're doing it to begin with, just because you didn't stop the medication. So often if you're on a vitamin K antagonist, or if you're on a direct 10A or direct thrombin inhibitor, I would recommend, if you're using these tests, to do an interruption. And that's why we don't do a whole lot of thrombophilia testing early on. We do it after 3 to 6 months when we do risk stratification, because then you feel comfortable about holding anticoagulation, because the risk of recurrence during the interruption would be relatively low. So we talked a lot about patients with standard clots, right? Those with DVTs, PEs. What about unusual site thrombosis? What about splanchnic vein thrombosis? If you read different management strategies and different clinical practice guidelines, they are commented on in the American Society of Hematology, the British Hematology Society guidelines. But I think if you have an unusual site thrombosis, especially in the splanchnic veins, I have a look specifically at the CBC to look for signs of hemolysis or signs for myeloproliferative disorders. And I tend to do a bit more testing for the PNH, the myeloproliferative disorders, APS in that particular setting. Because they're a bit unusual, maybe the underlying prevalence of these diseases is higher, especially if there's sign on your basic CBC, then my thresholds for testing for these is relatively much lower than it is for a lower than DVTs or PEs, for example. So I wanted some time for discussion, and I've already been talking for 40 minutes, but I wanted to leave you with some conclusions. So it's important not to test at the time of the VTE event, because depending on your assay, you may have some interactions again in your patients on anticoagulation, which may make interpretation difficult. If you're really worried that the patient may be triple positive APS because they had arterial and venous events, or it's very unusual site, then doing anti-beta-2 glycoprotein 1 anti-cardiolipin for reassurance, if normal, you know you don't have triple positive, may be reasonable in certain setting on a case-by-case basis. The second recommendation is to remember not to do testing while patient is receiving anticoagulant therapy, or at least know what type of assays you're using locally to make sure you can interpret these relatively well. Otherwise, do interruptions, and interruptions would be safely done after 3 to 6 months, and that may help you to stratify. There's no rush to do thrombophilia testing, right? So, pushing it back when you do the decision about long-term anticoagulation may be reasonable. I think there's no strong argument when you have a strong provoking risk factor to do it. And then, as we saw from the first case, some people would argue that COC may be a relatively strong risk factors, others not. I think you need to be very mindful about doing thrombophilia testing in the setting of provoking events. And then just have a reflection of why you're doing testing. Shouldn't be done routinely, because they may lead to adverse consequences you didn't think about. But if you do it for the right reason and the patient understands and you have a conversation around it, I think it's something that is very important. You just need to be able to identify the goals of your testing, why are you doing it, and make sure that the results will be acted on. You have an action plan based on it.